Welcome to Joint Effort PAs, where two orthopedic surgery PAs get real about life in medicine. From tips and tricks to professional growth, work-life balance, and everything in between. We're here to share what we've learned and what we're still figuring out. Let's get into it. We are back with a clinical topic, as promised.
That's right.
To go between our fun and our seriousness.
Well, we have to go both ways.
It is serious. This is serious business.
Well, I'll tell you, I had a lot of laughs after last week. I got a lot of good feedback after last week. Yeah. Well, I texted you a little bit of that.
Yes. I died when I saw that message.
Yeah.
That was a lot.
I know. Anyway, so we will continue to mix it up.
I think this topic is like, when I was thinking of things to do, I was like, this is so simple. And I feel like everybody probably thinks they know everything there is to know about it because it's something you just do all the time. But like, maybe you don't. I don't know.
Well, I think the difference in academic world versus in practical world, there's a lot of nuances. So we're going to talk about steroid injections.
Yes.
Administering them, thinking of administering them.
Deciding
them
when,
again.
when not to, all of those things. So yeah, let's get into it. Well, first off, how was your week?
My week was great.
Yeah.
My week was great. I was, I want to say off, but like, I definitely was not off. I was not in the office last week, out of office, but I did a lot of good things. I hired a medical assistant. I hired a PA. I hopefully found another PA. But I also did a lot of fun things.
That's exciting. Did you take any calls while on the beach under a blanket?
I timed them so that I was not on the beach. I was more in the clubhouse. And when everybody left the beach and I was left there standing in just my bathing suit and my phone, I was irate, like literally irate. I had to do like a walk of shame back to the house.
Do people like give you a hard time when they're like, oh, it's vacation, you're not working, stop.
You know what's funny? So my husband does not work in medicine. He works in construction. And if you've been following, he's had quite a busy past couple of weeks. He never brings work on vacation and scrutinizes me when I do. And he worked every single day.
Did he?
Yes. Just because he's got a situation where they hired a new guy and they fired a guy. So he's like, taking on this other guy's department. So he was on the phone all the time and I didn't hate it. Like I was kind of like,
did you feel closer to him because of that? Like, wow, look at us being the same.
A little bit. I really did. I was kind of like, I thought to myself, I'm like, wow, you get so mad at me when I take a phone call. But it was like every day until almost 10 or 11, he was like working.
That's awesome. Why do I think that's awesome?
Well, I'll tell you what's awesome about it. Well, what's awesome about it is my sister came with us on vacation. My sister is me. So we woke up every day at 5 and then we went to the gym or running or took the dogs out. So we could do our thing in the morning. And I wasn't like taking away from time that I could have had because my husband was working. So by the time he was checked out and I was ready to go, it was beach time.
I love that.
Yeah, but it was good. How was your week? Did you hold down the fort here?
Yes. Yeah. It was a busy week. But it was good overall. Like a lot of case variety, some big fracture cases, another thumb replacement. So
how many have you guys done now?
Oh gosh, we're at like 8 now.
I was saying like at least half a dozen.
Every week we're doing more and more and more. We actually did the first one this week where it was like a maybe not situation because it was questionable and ended up not doing it. But yeah, it was good. Just a lot of variety. This week will be even busier. I think we're already scheduled for 22 cases this week.
Oh my
22.
gosh. Yeah, that's a lot. That's a lot.
Yeah, it is a lot. And then my doc is out the entire week, the week following. So
I saw that.
So yeah, it'll be interesting, but I'm ready for it. I'm pumped. I'm thrilled. I have bought a lot of like double shot espresso in preparation. And it's going to be a great week. Can't wait.
Do you guys have like the football rush when it hits August?
Yeah.
Will you have that?
Yeah. I mean, I feel like some years it's been worse than others. Last year, I really don't think we got hit with a lot of football injuries. We'll definitely get a few here and there.
Burning question. Will you cover any football?
I was going to, and then I looked at the list. Now, in the defense of everybody else, I might have taken like a week and a half to 2 before I actually pulled up the list that was sent out, but they had already been, the school I typically cover was covered. So
yeah, that's funny you say that. I looked at it yesterday and I was like, oh my God.
Yeah.
Yeah.
So maybe not.
Maybe
we'll
not.
see.
Yeah.
I covered a high school, and I like doing it. I mean,
Yeah, I don't mind
from the past.
I don't mind doing it. I definitely have 1, 2, 3, 4. I had like 7 last year, which was like, it was a lot. I have about 4 this year. So it's 5. I miscounted. Anyway, I'm here for it.
Yeah, no, they're fun. I'm sure I'll end up filling in for one of them. I just don't like to go to the ones that are like really far away.
Yeah, no, I hear you.
Not fun for me. So, all right. What is fun for me are injections, though. So love doing injections.
I know one of the main reasons that I like ortho, and then when I have students or like have like new grads, whatever, like it's very procedure heavy.
Yeah.
And you even more so. You guys are splinting, casting, setting, taking pins out. We do injections all the time.
Yeah.
I think more so
10 a day at least.
Oh, at least. Yeah. I think more so than like what academic world would suggest is normal.
Yeah, or appropriate.
Well, no, I mean, I think just being in the specialty we're in, anti-inflammatories and steroid injections are like go-tos.
Yeah. I mean, I probably use steroid injections significantly more than I use like prescribing oral anti-inflammatories.
Oh, yeah.
I don't really like to prescribe oral NSAIDs because one, when people come to see a specialist, they probably already tried that.
Yes, very true.
And that's something that like maybe their PCP would have recommended and suggested, and I need to offer them something that's different and a little bit more aggressive by the time they get to us.
Yeah.
And we have the more nuanced options we can offer. Yeah. So steroid injections, there's multiple types of steroids. I feel like, it's highly practice dependent, and then based on like what the docs you work with have used in their training, as far as the dose you use and the type of steroid you use, because I worked with some people in the past who use dexamethasone versus Kenalog, which is primarily what we use here.
Triamcinolone.
Yeah. So, the difference between the two, so dexamethasone is water soluble, triamcinolone, Kenalog are fat soluble. So they linger around a little bit more, so longer lasting effect, but sometimes more of a side effect profile with the Kenalog and triamcinolone than Dexa. So yeah, we'll get into a little bit of that, but injection wise, so you probably do more steroids than anything else, right? You do HA.
We do HA. We use steroid injections intra-articular. So whether that is knee, I do them knee, I do them ankle, I do them CMC. I know you do. Cleniohumeral, AC joint.
Yeah.
And very, very effective for localized pain, especially if patients already tried the oral anti-inflammatories. Different though than hyaluronic acid injections, different than PRP. I will also use steroid in some of my nerve blocks. So whether I'm doing like a radial nerve block, radial nerve block, carpal tunnel injection, or even a geniculate nerve block. So big fan of using just like a really low dose steroid in a nerve block too.
Do you still use triamcinolone for those, or will you use Dexa for those?
Dexa for my radials. Yeah, I do triamcinolone for my carpal tunnels, although I've had a couple patients that splinter skin. So
yeah.
Moving on.
Yes. That is one of the side effects with it. So first off, what are our thoughts on steroid injections? Are they good? Are they bad? What do you say to a patient when they come in and they're like, let's say you're seeing them, because this is highly dependent on what you're treating, how you're going to answer it. Knee-OA. We'll start very simple. So you offer them a steroid injection. They're like, well, isn't that just going to like mask my pain? Isn't this just a Band-Aid? Like it doesn't fix the problem.
Yeah. Let's do a whole segment on like the conversation surrounding the steroid. Patient comes in, their friend told them they need a steroid injection. They're kind of like ready to go. I'm here for my steroid injection. And then like they ask for it. And I love those visits because you're like pinpoint,
you know what you
want. But when you're taking the cap off the needle, they're like, wait, but I just had a steroid injection like last week in my back. Is it okay to have one today in my knee? But my friend said also like it kind of eats away my cartilage. So like, do you think it does? Is the one you're going to give me, is that going to do that? Also, I'm diabetic and I'm not supposed to get an injection.
And my A1C was 8 last
week. And my A1C was 8 today when I woke up. But anyway, or aren't you going to use ultrasound to inject my knee with that steroid injection? So the conversation, right?
So many things.
I have so many things. So when a patient comes in wanting a steroid injection, I will go through the whole, what is a steroid injection and why we do it? Like, how does it work? Right. So like an anti-inflammatory, it is, our Advils and our Motrin are NSAIDs, non-steroidal. This is a steroidal anti-inflammatory. This is meant to decrease inflammation, let's say in your knee. Okay. It will not make your knee not arthritic. It is not going to reverse the pathology of your knee. It is literally meant to treat the inflammation from what you have. If you are not hurting today, I would not do a steroid injection just because you have arthritis. Right. So when patients come in and they're like, I'm here for my steroid shot, but actually my knee feels fine today, I will discourage them from doing that. Yeah. A very good example of when it is appropriate is someone overdid it working in the yard and their knees like killing them. Perfect. Acute on chronic flare-up. Perfect situation for a steroid. Someone who's about to go to Disney and walk like 20,000 steps when they're used to walking 2,000. Perfect. Perfect for a steroid. But I will have the conversation with, yes, we use these. We use them as frequently as possible, right? So I like to space them out every 12 weeks. If a patient is diabetic, I will alter the dosage. I will also educate them that it will throw their glucose into the 300s for a couple days. They definitely need to know that. And then I'll get in the conversation about ultrasound. But I have a nice spiel about what it is, what it's not.
For ultrasound specifically?
No, for steroid. Just for steroid
in general. Yeah. I tell patients like in simple terms of, oh, this is just going to mask and cover up my pain versus cure it. Yeah. For arthritis specifically, yes, you're right. Like what you're saying is absolutely 100% right. Yeah. We are going to mask and cover up the pain, but you have a degenerative condition that is not going to reverse itself. You're not going to regrow cartilage magically because we just haven't gotten there yet. Maybe one day. And so you are wanting something right now to feel pain relief, right? Like you're hurting, you want to be able to do the things you want to do pain-free. So this is an option to get you there, to allow you to do those things. And yes, there are definitive options for it, like joint replacements. We can cross that bridge when we come to it. This is for you right now to feel better. So
yeah. Now, like, okay, but what about the Band-Aid? Like, you've got the CrossFit guy that is like, but it's just a Band-Aid. Like, I don't really want to do something that's not going to fix my problem. Well, okay, let's launch into your shoulder. So you've got rotator cuff impingement. You clearly are still working out. Yeah. It bothers you sometime at nighttime and there's no weakness whatsoever. So in this case, I would maybe use a steroid injection to decrease the inflammation. Then also we pair that with, posture correction, physical therapy, whatever, and we go from there.
So that's an instance where I would tell them like, we can think of it more as a curative thing because we're not using it to just purely mask something. Right. This is a part of like the treatment algorithm to get you long-term pain-free because you don't have a massive tear that we're just covering up the pain from. You have this like snowball effect inflammatory process and you need to be able to tolerate the therapy and XYZ. So those are different scenarios. And so I think there is like a nuance of injecting people with arthritis for, flare-ups.
Acute on chronic.
Yeah. Versus bursitis, impingement, tendinopathies. That's a different story.
It's a different story. But I think you have to educate the patient. You have to be educated on where they are in the tendinopathic cascade or on the spectrum so that you know when to use it and when to stop using it. Yeah. Also for patients who have massive tears who don't want surgery, hey, can't I just do a steroid? That's also a different conversation. So some people, 85, non-dominant arm, never going to have surgery on that arm. Sure. Yeah. We can do a steroid, but every time I see them, I'm like, just so you know, this is not fixing your tear. Right. At 85, it's probably contributing to it worsening. Yeah. but if we have made that decision that is what we are doing, then that's what we'll do.
But is that person going to be a good candidate regardless for a primary cuff repair?
Oh, no.
So
no, we've already made that choice.
And, I'll tell them that too. I'm like, look, it might be worsening, but are you going to have a primary cuff repair? Probably not. And like the success rate wouldn't be super high either. So at that point, it is a temporizing palliative thing until you send them to us.
I know.
For reverse. Yeah. So, Yeah.
Yeah. Now, so the steroid itself decreases the inflammatory response, right? So it interrupts the inflammatory cascade. When we administer a steroid by itself versus with any local anesthetic, do you see that the patients have a different response? Do you always mix yours with local anesthetic?
I never do it in isolation unless I'm like doing some sort of procedure where I'm pre-injecting lidocaine and then just the steroid afterwards. So there's still lidocaine in it. Like, for example, I have some patients that CMC injections are super painful. Yes. So some of them I'll pre-inject lidocaine. I'll like do a wheel over the skin and then go ahead and push some into the joint, because like the joint expansion itself can be painful. So I'll give it like 5 minutes or so, and then I will just do plain steroid, but there's still a mix of lidocaine in with it.
Yeah.
That's already in the joint. So
yeah. Now, what is your spiel with how quickly it'll work?
Depending on what I'm treating, I feel like usually in intra-articular or for treating OA, a couple of days.
Yeah.
If it is something like trigger finger, carpal tunnel, I usually tell them up to 2 weeks, because it may help with the pain more quickly, but to decrease the inflammation enough to notice the effects of like decreased locking or their finger being able to bend completely, that can take a couple of weeks. So
local anesthetic immediately works on the nerves. Which is why we use that. It gets into the tissue faster, better. Where corticosteroids don't, it takes hours or days or whatever. So mixing that together gives them the immediate pain relief. But what I will generally tell them is, and this is mostly lidocaine plus a little bit of a steroid. The lidocaine is for the now, right? You may feel good now, but that will wear off. And then there's a little bit of time before that steroid kicks in. But steroid injections turn off genes that make inflammatory proteins, turn on genes that suppress inflammation. So they work kind of at a different level.
Yeah. So what do you tell people as far as like NSAIDs, like taking oral NSAIDs versus doing a steroid injection? I think an injection is safer most of the time.
Yeah, I think the way less systemic effects, and not to say there's no systemic effects. Steroid injections, when you administer them, they can cause a steroid flare. And if you're doing this 10 times a day, I don't want to speak for you, but I don't think you're educating patients 10 times a day that they may have these side effects, right? It's the patients you don't tell that always get them.
Yeah, they call back and they're like, oh my God,
my heart's racing. Yeah.
Like, oh, I'm dying.
Yeah. So facial flushing, a little bit of tachycardia, insomnia, increased thirst. What is that? Polydipsia? Is that what that's called? I don't know. I'm doing a little board thing right now.
They're thirsty.
They're thirsty. But no, it will have those systemic side effects, and it's always the patients you don't tell that to that it happens to. And very transient, like maybe for that night of, and then that's it. It will raise your blood glucose for up to 3 days, 72 hours into the 300s. So.
But Beth, will the steroid injection make me fat?
Oh, yeah, right. I don't want to gain any weight. So no. And again, I'm asked that at least 5 times a week.
Yeah.
Yeah. So localized injections, no, it's not enough as a systemic effect to give you Addison's disease or anything like that.
Yeah.
It will also treat other things. Like I had a guy I used to do knee injections for, and his psoriasis on his hands would clear up every time.
Oh,
so
nice.
Added benefit, right?
Yeah.
But also some patients are like, well, I'm on Eliquis and I can't take anti-inflammatories. I'm like, well, then this is the ticket for you.
Yeah. This is our only option.
Or Coumadin or whatever. Yeah. So some patients will come in and say, well, I need clearance from my cardiologist. I'm like, okay, you do you. Like, I'm ready to go.
Right.
Ready to do it.
And that's what I do the same thing in those instances, because I'm not like, I will educate people like, hey, your cardiac condition or being on blood thinners does not preclude you from getting this.
Right.
Like, I don't have a reason that me doing this would be wrong.
Yeah.
You're not going to bleed out from my 22 gauge needle, even though you're on Eliquis.
So what areas will you inject?
Almost anything.
I know, me too.
I mean, like,
me too,
I am,
dude.
like, so eager
like a little
to do
steroid
whatever,
there,
especially if nobody else will do it. Like, that makes me even more want to do it. It's like, oh, nobody else here wants to do that. I'm like, yeah.
Okay. So CMC.
CMC, yes, I do a ton of CMC injections. Love hate with it because people do really well with them.
Yeah.
They can be super, super painful, and they're actually, I feel like they're pretty challenging to do out of all the intra-articular injections. I do them blind typically. I just think it's easier for me to like
the hands
traction with one thumb. I don't have the extra like fumbling the small space of the ultrasound. And most of the time I can feel myself like pop into the joint and I can tell that I'm in there. But I do have a couple of patients that maybe didn't get great relief with blind ones. And so I do ultrasound-guided for them.
But Hannah, mine didn't work. You didn't hit the right spot.
Well, then I will do it ultrasound-guided to be sure.
But what if? We'll go back to that. All right. So CMC, yes. Trigger finger, yes. And how many times?
Yes. Hour typical algorithm is 2, but that's not like a hard and fast no. I mean, it depends. All of these things are so dependent. And that's why like it can be really hard to just give somebody an algorithmic approach. And like, this is what we do and why. Say you've gotten 2 trigger finger injections in the past, but they've been spread out 3 years apart from each other. Like
I'm good.
Sure,
good for a third.
I'll do a third one. But like, is this clearly a recurrent issue that like you wouldn't even have to be dealing with getting these repeat injections if we just released it? Yes. And then I will educate them, as with like any tendon issue, that there is some risk of tendon attritional wear with the steroid injections. There's some studies out there that have shown like X number of trigger finger injections, like you hit beyond a certain threshold, an increased risk of the tendon rupturing, which is bad. So
that trigger finger, also biceps tendon, proximal biceps tendon sheath. Love doing those injections, especially when you do them under ultrasound and you see the tendon is just like swimming. But I will always tell the patient there's a risk of rupture here. So again, this is a hard
in that sense, because it doesn't matter.
It doesn't matter. But if it happens, then they're like, oh my God, it ruptured. You need to fix it. If you don't have that conversation
before,
then you're screwed. But having that conversation, and again, if it ruptures, problem solved, right?
Exactly. Yeah. Then now I've permanently fixed it. I've done the
You're
surgery.
welcome. Yeah. But those ones I will be a little bit careful with. I will do them, but I will definitely tell the patient like, hey, listen, we can't just continue to repeat. But very different conversation with subacromial injections, like rotator cuff. Those ones, very low risk of rupture. But if you are continuing to inject the subacromial space, there is an increased risk of infection or delayed healing post-operatively.
Have you noticed when you're scoping somebody, like if somebody's gotten a shit ton of steroid injections, do you feel like the tendon looks shittier because of it? Or do you ever like see steroid material?
You will. Yeah, you will see a little bit of calcification from repeat steroid injections. But it's more so that than the evidence of the tissue just being garbage. Okay. I think the tissue's garbage because it's garbage. And if we've injected it, I don't think that's the reason why it's garbage. I would think you'd see it more with your trigger fingers. Yeah. Glenohumeral OA, I love injecting that one. Yeah. Just because.
Very satisfying.
Yeah, it's very satisfying. And same with AC joint. Yeah. But on a pain scale, AC joint, yeah. It's always those guys that legit pass out. Yeah. They do. Yeah. They just pass out.
And like you're right there. Like
you're right in their face. Yeah. Least favorite one to inject, SC joint.
SC joint. Ugh.
I do that though. Yeah. Again, that's the one no one will do.
It is the one no one will do. And I think I asked you the first time I ever did it, I asked you about it. I was like, ugh. Yeah. Can I do this? You were like, yeah, I do it under ultrasound.
Yeah. And you could see it it's like AC joint. You can see it very well, but you're in the territory that you don't want to like. You don't want to twitch. You don't want to twitch. I don't know.
Or subclavian.
Yeah. The tennis elbow I've done way less of just because I favor interarticular injections. Again, with that one, associated risk, if you continue to inject, that it's just going to essentially buy them the ticket to surgery. But
my doc's SC joint has been very inflamed. He's like, whoa.
Dude, say goodbye to his V-necks.
Oh my God. It was prominent. And I ultrasounded it, and I'm like, yeah, like it's clearly inflamed. Like, should we inject it? Like,
was he like, absolutely not? Oh my God! But for some reason, SC joint, when they're inflamed, women cannot handle it. I think it's the site of it. Yeah. It's a site of it, or they think it's a tumor. Now, will you titrate up or down based on effectiveness? Like
for the steroid, like
let's get into like timeline. So you said with your trigger fingers, you'll do them like twice and they have to be fairly far apart. With NEOA injections, and this is your patient that has, KL grade 3+. This is your 75-year-old, knows they need a knee replacement, but I mean, honestly, he's doing okay and honestly doesn't want anything.
The can down the road.
Yeah. So every 3-ish months. So I will tell them soonest I want you to come back is 12 weeks. I have some patients that count it out to the day, make their appointment. I have some patients that, they come in 12 weeks, but they really needed it at 8 weeks. So I will titrate up. We do a 40 milligram, at least our team does for standard. I will titrate up to 60 and the highest I'll go is 80. We have some physicians that start at 80. Yeah. That's just what they give. Yeah. I have some patients I'll start at 20.
Does that help them get longer?
Yeah. I think it buys them a little bit more time. Yeah. But it's always a conversation of, but the last one didn't work. You didn't do it in the right place. Well, these also have a shelf life. Yeah. I can't make a chronic problem not chronic.
Sometimes it's just going to be more effective than others. Like I've seen some patients that like for CMC arthritis, for example, I've injected them, maybe 6 times at this point. And it goes the same way every time. I'm not doing anything different. I'm not like noticeably feeling like one of those was not correct. And some just don't last as long as others.
Yeah.
So, it happens. There are some times where like, you're like, not 100% sure if that was in the joint or not.
Oh, yeah.
Yeah. And I'm like,
I had one of those like 2 weeks ago. Yeah. And it happens. The shoulder ones, I feel like, because I do my glenohumerals under ultrasound, those ones I feel pretty good about. Like I can see it get in the capsule. And I'm like, okay.
Yeah.
The knee injections, like I have one lady that is so valgus. We're talking like 45 to 60 degrees. I put her in a hinge knee brace because she's 85 and it strains her out the most, but she replaces it every 6 months because she wears it out.
And you still inject lateral for her?
Absolutely not. I inject medial, but I got to the point where I was like, oh, dude, I don't even know if this is like, yeah, there's like a handful of those that I have.
Yeah, those are a little bit disappointing for me because I know when they left, they're like, oh, thanks so much. I'm like, oh, fingers crossed.
But will you use ultrasound anatomy wise if you're questioning it?
If I'm questioning it during?
Like in your, yeah.
I mean, yeah, like I very rarely use it for CMC injections. I just feel like it's too bulky and it gets in the way, but
it like rolls off. And also the probe is so, I know you guys have a smaller probe, but the probe like rolls off of the.
Yeah. I use it like in plane.
I do too.
And I would just want to like see the tip of the needle dipping down under the first metacarpal head. Yeah. And then I will chuck the ultrasound, not literally, I don't throw it across the room against the wall, but like
I could.
I set it aside. I could. That would be fun and dramatic. I set it to the side gently as to not damage it, and then pull traction, pop through the joint, and do the injection. And hopefully remember to save the ultrasound images for billing.
That's right. That's stuffy. And you don't have 20 hands.
Do you ever, CMS is going to audit me for this. Do you ever like take the picture after you've done the injection?
Absolutely.
Like you're like, oh, I forgot to save it. Like,
absolutely. Absolutely.
Yeah.
Mm-hmm. Just to say I was there.
Yeah.
Now, we talked a little bit about side effects, but the biggest one, at least for us, we do geniculate nerve blocks. And on most patients, their medial inferior geniculate nerve, it's very superficial. Like you barely need a short 25 gauge needle to get down to the bone. I mean, there's a lot of people, some people there's a big amount of fat, some people there's not. The fat atrophy that occurs in that area sometimes is like appalling.
Dramatic.
It's dramatic. Yeah. And it's always the females that just care.
So those are like one of the big 2 things that I will tell people is like side effects physically that they'll notice from a steroid injection in certain areas. So that area in the knee. For me, it's de Quervain's injections, very superficial.
Yes, right there.
And I use ultrasound for them so they can be in the tendon sheath to maybe decrease that a little bit, but people will still get it, especially if they have a darker skin tone, it's going to be more noticeable. And I was looking at it before this, like the incidence, and typically it takes a couple of weeks to months sometimes to notice the skin blanching, and it does typically resolve over the course of like 6 to 9 months, sometimes a year, and then sometimes in rare cases, not at all. I know.
And I've read like 18 months in some people, if at all, right?
Yeah.
And that's just unfortunate. But I've spent because I manage, other departments. I spent time on the phone with this one patient. She's like 26 or something. And she got an intramuscular dexamethasone. Now, let's just talk about that for a second. It's an intramuscular injection.
If someone is intramuscular triamcinolone or
no dex.
Okay.
Intramuscular dex for acute like back pain or something. So she got an injection in upper outer glute and she called back. She's like, there's a divot. I was like, that's like impossible.
Yeah.
I mean, I didn't give the injection, so I'm like, okay, maybe it was possible. Yeah. She's like, I can't live like this. Like I need to know how to fix that. So we had her come, actually she didn't come to us, but she went to her dermatologist to do an HA injection in the fat.
That's amazing. I would love to do that.
I know. So I've had conversations with patients who I'll see it on their knees and I'm like, okay, if and when we do your visco, let's save a little bit and throw it in the skin area. I've yet to do that and been like, wow, that works. But something you can try that would be super low risk.
Yeah, I wanted to at one point for, because sometimes for CMC injections, if you're not in the joint completely or if like some leaks out of the joint, especially if they've had like a bajillion of these, you can get a lot of fat atrophy and skin thinning around that area. I'm like, what if I just like inject some filler into it?
Yeah, you could.
You know?
Yeah, you definitely could.
That'd be cool. So actually, I was at a point last year. Was it last year? I was on this kick about hand filler. So you can inject filler into like the dorsum of the hand for when your hands look creepy and
Do
old.
people want that?
Well, yeah, like the internet said that they did. And
yeah,
ChatGPT thought it would be a really good revenue stream for us. And I got super excited about it. And I was like going to do a training on it. And it was super expensive. And then I talked to like, first of all, it was awkward patient finding because I would look at their old people hands and I was like, you know what? You know what? Like.
Yeah. Wait, do you think my hands look old? No.
Then, like,
I mean,
90% of people were like, oh yeah, that's really interesting. And then when I told them the cost, they were like, it's not that interesting because it's like close to $4,000 to have both hands done. It's a lot. I mean, at that point, I'd rather get everything else done up here. So
yeah, true.
I was pointing at my face just now in case anybody was.
That's unfortunate. And then diabetics, I will use sparingly. Those that are really brittle, uncontrolled diabetics, I don't like giving them full dose steroid injections.
Yeah.
Or I will have them like have a backup plan or something or get clearance from their doctor or whatever.
Yeah.
But I will have patients that'll say, no, it's fine. Like my knee's hurting so bad. I just want the regular dose because I know the half dose doesn't work as well. Oh, okay. But the risks here, like I know you're on insulin, you have to adjust. And I had one guy who came back, he was like, hey, so I almost went into DKA. And I was like, wait, what? Like, but you wanted it. You said it was okay. He goes, I know, but this has happened a couple times before. I'm like, buddy, let's fast next time before we do that.
Gonna kill you.
Good
God.
But I will have some patients that they will say that their endocrinologist like will not let them have that.
I mean, I guess I get it.
I get it.
But,
yeah.
You know,
but they're in our back pocket. Like they're very, very practical for us.
We talked last week about tennis elbow and using it for that and how we feel about that. So I won't belabor that. The hard nose, Achilles.
Yeah. Patellar tendon.
Distal biceps tendon. Patellar tendon.
Mm-hmm.
Yeah.
Plantar fascia. Did you ever do those in urgent care?
Yes. I liken that to like a tennis elbow injection. I won't say high, but like there's more of a risk of rupture. And you probably don't want to do a bajillion of those.
I feel like though rupture your plantar fascia, that's like literally the release.
Yeah.
Right?
Yeah.
So I feel like you're
more like the biceps, I guess. It's more akin to that.
Yeah. I would think more with the plantar fascia, it's more like a needling procedure anyway. You know what I mean? Like, let me just micro needle this and see if I can fix it for you.
And that's sometimes what we'll do for tennis elbow specifically is just like needle the shit out of it. Yeah. It's almost like an in-office 10X procedure, PRP without the PRP.
Yeah.
From a billing standpoint, like tricky to figure out.
Yeah, very tricky. Now, perioperative use of steroid injections. So for knees or for joints, well, actually for rotator cuffs, we will make a patient wait 6 weeks from subacromial to rotator cuff repair because there is research that will show that they will not heal as well.
You said 6 weeks?
6 weeks. Yeah. Sometimes 8, depending. Intra-articular knee injections, if they want to have a total knee replacement, I think across the board at our practice, the surgeons wait 3 months. Like there must be a 3-month washout, which kind of sucks because, you know, if you're hurting and you want to have your knee done, you just have to sit there and hurt. We do use intra-articular Toradol injection. So there is some good research that shows that is effective. Yeah. I don't think obviously they work as well, but I will have like a handful of patients every year that's like, oh my God, that works so much better for me. Yeah. Really? So
yeah, I don't know. I mean, we actually won't even for any intra-articular injection, even if it's Toradol, do the total within 3 months of like any needle entering the joint.
It's safe.
I'll offer like nerve ablation procedures or Ivera for those patients. So that's another option. But yeah, 3-month hard window for totals. Everything else, as far as like surgical, like tendon issues, 6 to 8 weeks typically. So
do we love steroids?
I do because I feel like that is a large part of your practice as a PA. Like that is procedurally what you are doing. That's like your main revenue generator. That's your main like independent procedures that you can do. And it's fun. Maybe is fun. Not for the patient always.
That is true.
Mostly for me. Sometimes not for me.
I think educating the patient though, as to what to expect, educating the patient why you're using ultrasound and why you're not. Like for knees, sometimes like, why aren't you using ultrasound? I'm like, you know, fighting everything in my being to be like, I don't have to.
Yeah.
But like AC joint, I like to use it.
Yeah.
Interarticular elbow, I don't. Interarticular knee, I don't. CMC, I do, unless like I don't. Trigger fingers, I never do.
Yeah, I was on a kick for a while where I was trying to use it because I was just, I don't know. This was one project of many in my mind at the time. And I was like, I'm going to use ultrasound for literally everything.
Yeah.
And I don't know. It's just like, it wasn't as easy.
It's too cumbersome.
It's bulky, it was cumbersome.
Yeah, there's not enough room on the hand.
And that lasted literally probably 3 clinics before I was like, F this. Like, I'm just going to go back to doing it the way I was before. Carpal tunnel injections. Now, I did, I had one patient not too long ago who got a carpal tunnel injection in an outside practice. And from the way she describes her experience, it sounds like they probably hit her nerve.
Yeah.
And said it was super painful and didn't work at all. And things felt like they got worse temporarily afterwards. So I did use ultrasound for her. More than anything, like I was fairly confident that I could do it blind without hitting her nerve. But because she had that experience before,
I totally would have done ultrasound.
And then that way I can literally look at your nerve while I'm doing it and we will know that it's not in your nerve.
Yeah.
So.
Also, you will not feel electricity. So
yeah, it'll be amazing for you.
Yeah.
And it was. She was like, wow, that didn't feel anything like the last one.
I had a patient one time who said that the first several times she had a steroid injection in her knee, it hurt so bad. And when I did it, it didn't hurt. So she called back wanting another one because I couldn't possibly have done it right. Also, her knee didn't hurt anymore.
Yeah.
So she wanted me to comp her a steroid shot because I didn't hurt her enough. She still got the outcome she wanted, but the expectation was not there. So she wanted a free
injection because it was better.
Yeah.
It worked and it didn't
it worked. It didn't hurt, but it could not have been done right is what she said.
Interesting.
Yeah.
Yeah. Those are the ones that I'm like, I want to understand.
I want to understand, but what am I now? I'm trapped. If I refuse to, then I'm not satisfying the patient. If I do it again, now I'm putting way too much steroid on their knee. If I do it again, I put mostly lidocaine and a little bit of a steroid. It's a win-win, but I do it for free. Like what? But anyway, so steroids calm the fire. They don't rebuild the house.
I like that.
Right? What is the other one? There's another one.
A good description of it.
It's turning down the volume on inflammation, not fixing the broken speaker.
Oh, okay. Interesting. So yes, hopefully this is helpful as far as when to use them, when to not use them, and just, learn a little bit more about them.
Yeah. Don't be afraid of them. I think it was very scary. Like the steroid injection in a joint was like scary. You're taking a sterile environment. You're sticking a steroid in there. I feel like when I got into practice, I'm like, it's not that scary. It's
not that scary.
Yeah.
I mean, know your anatomy.
Yeah.
And know your landmarks. And I mean, that's the gist of it.
That's right.
Yeah. I mean, obviously it is a sterile procedure. Mm-hmm. So don't rub your arm against it before you do it and not clean it off or something.
That would be bad.
That would be bad.
That would be bad.
Yeah.
But very interesting. We should do one of these weeks talking about PRP. Just as a different, I mean, this is not a comparative discussion today. We could have made it one, but I think PRP deserves its own time in the spotlight.
It does. We do a lot of PRP and a lot more as of recent. So we should have somebody has in-depth knowledge on biologics.
We should. I wish we knew that person.
Come join us for that. So maybe not. We'll see if they're too busy for us.
All right. Well, here's to a good week this week.
Yes. It's going to be great.
It is. Thanks for tuning in to Joint Effort PAs. If you enjoyed this episode, be sure to subscribe, leave a review, and share it with a fellow PA or med-minded friend. You can also follow us on Instagram at Joint Effort PAs for updates and extra content. See you next time.